Thank you, Professor Atul, for this wonderful opportunity. So I'm going to talk about myopic foveoschisis. What is foveoschisis? Because we have been seeing patients with myopia for such a long time. It's only with the development of more sophisticated imaging technologies, mainly OCTs, that we are seeing more and more of these terms. Now, what exactly it is? Very simply, we all understand that in myopia, the globe is long. There is excessive axial elongation of the globe. So patients with these myopia, they develop posterior bulging or ectasia of the globe, and that causes posterior staphyloma. We all understand this. Now, the abnormal contour of this staphyloma causes some anatomical changes in the vitreomacular interface. So the patients develop macular pathologies like foveoschisis and eventually the hole. These all are a continuum spectrum: foveoschisis, foveal detachment, and finally developing onto macular hole. Generally, they are seen in 8% of highly myopic eyes, and typically seen if the axial length is more than 31 mm, if you have macular chorioretinal atrophy, posterior staphyloma, vitreoretinal interface abnormalities, and both intraocular as well as the outer wall factors would play an important role. Now, what exactly produces these changes is not very well understood. However, there is an implicated role that the ILM in myopes is rigid, and that is rigid because of the collagen fibers and some cellular components, so it causes the traction at the vitreoretinal interface. There is another hypothesis regarding the retinal vessels, that there are peravascular migration and proliferation of glial cells, retinal microfolds with coincidence appearance of the folds and vessels, which suggest a role for invert retinal vascular traction. This is what it looks like. If you see, this is the patient seen in 2013. If you look at it clinically, you really can't diagnose foveoschisis in most of the cases when you do a clinical exam in a myopic fundus. But when you do OCT, you realize there is foveal detachment, there is schisis, so this is what it is. Now the general question would be, why would you want to do surgery at this point of time? The reason is that 50% of these patients will progress to more serious complication. Now let's see, at this point of time, the intervention was not done. So in 2014, when you see the schisis and this serous fluid has increased. So 50% of them are going to progress to advancement and finally to the development of macular hole. So that is one of the reasons that the surgery is indicated in these eyes. The opposite eyes may show the different ends of the spectrum. For example, when you look at this, the right eye is showing myopic schisis, whereas the left eye has already developed a macular hole. Even the macular hole, sometimes because of the poor contrast in myopic eyes, you may not be able to appreciate clinically. So doing an OCT is a very important step if you want to make the diagnosis. So the natural history is very poor, and 69% eyes would progress with worsening of the visual acuity. So what is the treatment recommended? Treatment is vitrectomy, ILM peeling, with or without gas tamponade. And following PPV, it has been shown that eyes that have foveal detachment, they actually show better improvement in visual acuity compared to those that do not have foveal detachment. Now an example. This is a patient, high myope. You can see areas of chorioretinal atrophy, increased axial length. Vision is 2400. You look here, you are not sure exactly what is going on till the time you do OCT. OCT shows you there is a traction, there is foveal schisis, so the patient undergoes vitrectomy. Post-vitrectomy, you can see the traction has been relieved. This residual fluid takes some time to go away, and this is 10 weeks later. The vision has improved to 20/40. You can see this now is seen much more clearer than before. And I'm just going to show you one video, what is the optimal surgery. This is again a 65 man who comes with the right eye distortion of vision. You can see there is a lot of traction here, schisis. So the surgery is fairly safe, straightforward. You do the core vitrectomy to remove this. The vitreous tends to be very adherent in myopes. So sometimes creating the PVD might be difficult. So in this case, you can see a diamond dusted was tried to peel off the posterior hyaloid, but it was not really very helpful. This was followed by active suction with the Vitractor. Again, it made a very little difference. And one word of caution, if you are applying very high suction, don't forget to look at the periphery, because sometimes you might induce, the PVD. And in this case, we finally used the Mexic grip to remove it. And the dye was used to stain the ILM. And you can see this is the peeling of the ILM. It's important, many a times in myopes, you may not get the ILM as a rhexis because it again is very adherent. You may have to do it piece by piece, removing the ILM. As I said, ILM has rigidity to it. ILM is responsible for the causation. Therefore, it's important to peel off the ILM nicely so that the primary cause of the vitreomacular traction you are taking care of. So the ILM is peeled off. You do the peripherally hyaloid is removed, fluid gas exchange. So that is how it works. So to conclude, high myopia produces a lot of pathological alterations in the fovea that results in visual loss. And it's important not to just shoo away the patients with high myopia just saying that, okay, it's all related to myopia, because some of these macular pathologies are treatable and respond very well to surgical management. Foveoschisis, once you diagnose it on OCT, is progressive in nature. And it appears that the optimal timing for surgery in patients with myopic foveoschisis might be when the foveal detachment develops, because this helps in improving the patient's vision and prevents the formation of myopic macular hole. Once again, thanks to Dr. Atul.